Good morning, everyone. Thank you for joining us. It is raining in part of the country that some of us are. Hopefully things are a little bit better where you are. This is a special program. This is going to focus on management of patients with non-small cell lung cancer in the era of COVID. We've managed to get together a pretty distinguished panel of experts who are all involved in the care of patients with lung cancer. And given the current situation, we thought it was appropriate to have a forum like this where we can not only share some of our experiences, but also talk about issues that we are all struggling with. We are fortunate enough today to have an expert from Italy, Dr. Marina Garasino, who unfortunately has gone through this at her institution to share some of the difficulties that they have faced managing patients with lung cancer or possibly other malignancies in this era. So for this program, we do not have slides. We basically decided to make this a discussion, and we encourage you to participate by submitting questions so that we can answer them. Please keep in mind that we don't have time to go over every single question, but we'll do our best. Each one of our panelists will get 5 minutes to open a specific topic, and then we're going to come back and have a panel discussion and go over your specific questions and answers. So with that in mind, and to give a specific instruction as to how to use the Zoom, as a very close friend of ours just called and told us, we have all become Zoombies in this era because we have to stay home and use virtual meetings. So in order for all of us to become expert Zoombies, let's ask our expert to walk us through the basics of how to use Zoom and how to submit questions. So please take it away, John.
Good morning, good afternoon, good evening, depending upon what time zone each of you are in. So for those who have joined, this is a Zoom webinar. And for Zoom webinars, you will be able to submit questions to the panelists. To do so, at the bottom of your screen, or the top of your screen, depending upon which platform you're using, you'll see a Q&A button. Within the Q&A button, you will be able to submit questions to the panelists. The panelists will then be able to review, and then we'll respond with their answers during the appropriate time. Thank you all for joining, and we look forward to a great talk.
Thank you. So with that in mind, our first panelist is Dr. Tofi Owonokuku from Emory, and he is going to talk to us a little bit about the virus as an oncologist, and then start us off by talking about specific issues related to immuno-oncology drugs. So Dr. Owonokuku, please.
Thank you all. Good morning. As we are battling this epidemic or pandemic, I think it's good to at least remind ourselves what we're dealing with. So the SARS coronavirus 2 is a member of the beta coronaviruses, a single-stranded RNA, which is similar to some of the other viruses that have caused epidemic respiratory illnesses in the past, such as the SARS, as well as the Middle Eastern respiratory symptoms in the past. Most recently, we encountered this starting out from Wuhan in China. The unique thing about this virus, as we're all learning as we go, is that it's highly contagious, and no one has pre-existing immunity. So with that in mind, every one of us, patients and care provider alike, are all susceptible, which then makes it important for us to understand what we can do to protect ourselves as well as protect our patients and the entire community as we battle this pandemic. What we've come to understand, at least from the WHO and the Chinese data, which is where we have most of the information now, from tens of thousands of patients analyzed in China, is that specific population of patients are particularly susceptible to the toxicity and morbidity associated with this infection. Unfortunately, most of those characteristics pertain to our typical lung cancer patients. These tend to be elderly patients, the 20% of patients where you have very, very severe infection that tend to end up in the hospital. They tend to be patients with cardiovascular morbidity, diabetes, high blood pressure, as well as cancer. So when you look at the mortality rate or case fatality rate in general from experience in China, it's somewhere around 1 to 2%. Unfortunately, it's much higher in Italy, where it's tracking around 9 to 10% now. Fortunately for us in the US, it's still around 1%, but that might change over time as we get more and more of these patients into the healthcare facilities, and we hope that we do not get overwhelmed, because I think this is what is driving the fatality. So with that background, how does this impact what we do for our patients, especially in this era of immunotherapy? We know that immunotherapy, especially those targeting the PD-1 axis, have now become the mainstay of our treatment. And I'll quickly go through this just to be concise. For what we do for our newly diagnosed patient and how this pandemic is going to affect us and what we can do to modify our practices, we now know that for newly diagnosed small cell lung cancer patients, for instance, addition of immunotherapy to chemotherapy is the best option we have. Chemotherapy is the main driver of this benefit. Therefore, for our newly diagnosed patients, we may not have the leeway of delaying treatment for patients with extensive stage disease who may be very, very symptomatic. At the same time, we do not want to compromise on the immunotherapy. So what can we do in that situation? One is, the more we can limit the contact we have with patient and the patient has with the healthcare facility, the more successful we are in breaking the transmission of this infection. Therefore, one approach could be go back to our old doctor's box, if you may, which is instead of having the patient come in 3 days in a row for chemotherapy, can we use oral chemotherapy along with IV chemotherapy? For those with locally advanced disease, I know some of the panelists will talk about that, we will use different stages of immunotherapy during the consolidation phase. And for the advanced stage disease, I think this is really where we can impact what we do for patients in terms of schedule. Can we lengthen the schedule of administration, and do we have to see patients every time they get immunotherapy? Looking at long-term toxicity for those who have become established beneficiary of immunotherapy, two things come to mind. GI toxicity is not that common in our patient, but it's possible. But GI could also be the symptomatic presentation for patients, as well as pulmonary toxicity, which you can see in patients who have been on immunotherapy for a long time. So I will stop there, and we'll have opportunity for discussing this further as we go along. Thank you for joining us.
Thank you, Dr. Owunikukwu. That was excellent. We're going to move into the testing, and we are, again, very fortunate to have Dr. Kurt Schaffner from Yale here to tell us a little bit about the available testing platforms and some of the differences. So, Dr. Schaffner, please go ahead.
Thank you very much. I think this is, testing is usually an unappreciated component, and there are a number of reasons why testing becomes so important. The first reason is because it's essential for case identification and proper tracing of those cases, particularly at the early stages, and then also for identification of the animal sources that are common in this type of diseases. It is also critical to have an accurate test to be able to identify subclinical cases and ultimately for making rational decisions on how the disease is spreading. So really testing as accurate and as massive as possible is the goal. Today, there are three major ways that we can detect this virus. The traditional way is the viral culture, but it's actually impractical because it requires really high level of biosafety, level 3, and it takes a long time, so it's not really an option. The second way that it's available is the antibody detection using ELISA, but this test is actually not direct in the sense that it detects immunoglobulins, and they're not really as accurate because they can also recognize other type of coronaviruses because they have high sequence homology. And the final test that it's being actually used now is the reverse transcription real-time PCR, which is highly sensitive, and it can actually be used in multiple type of specimens like nasopharyngeal swabs, sputum, or even saliva. I think at this point, the most important point is that the sensitivity is high and it can be deployed in a relatively rapid way. And I'll go back to that. I think what we are seeing is that it hasn't been as smooth to actually generate the amount of testing. And I will discuss now what are the major barriers that we have seen so far. And the one and first is very domestic, which is actually a true limitation of reagents and resources to both do the sample collection and also to do the testing. Relative to the sample collection, there is a limited amount of swabs, vials, and actually protection device for the care people to actually do the testing in a massive way. From the reagent standpoint, there's actually a major bottleneck in obtaining extraction kits for nucleic acids and master mixes. And now I think we have been a little bit better, and there's a lot of incentive to actually generate more reagents. A few other aspects that have limited the testing are the relatively rush and confusion about this emergency status to get approvals. And there's actually have been a few concerns about the test developed by the CDC, where some of the controls were not working. So there has been a little bit of confusion. And also there is this emergency approval status required by the FDA, which prevents sites to actually use their LDTs. And there is a fair bit of paperwork to get that emergency approval, which now is actually working. As of today, we have 20 tests that have been approved. Finally, there is also a bottleneck in the reporting. There is not enough personnel to report that many tests a day. We're talking about 1,000 to 2,000 in large labs. And ultimately, there is a little bit of confusion about what is the best RT-PCR assay. Since the gene has about 7 possibilities to target using RT-PCR, there is not complete clarity of which targets are the best ones. And so far, there are a few reports, but there is up to 15% difference in the testing relative to the genes that are targeted. So I think we'll learn much more about that. And with that, I think we finish the diagnostic, and I'm happy to take questions.
Okay, thanks, Kurt. We'll do questions in the panel. So now that we've heard a bit about the virus and we've heard a little bit about the impact on some of our therapies, and testing is so important. It's just a new test announced by the FDA in the U.S. this morning. We are really fortunate that Dr. Marina Grassino from Italy is here. And they're 3-4 weeks ahead, maybe a little more or less, but we asked her to join, and we're going to give her a bit longer to present, 10 minutes, then with 20 minutes of questions. And so start thinking of your questions. We were all hearing about Italy, so here we have someone who's on the front lines, a very highly regarded, top lung cancer researcher in the world. So Marina, thank you for joining us today. And if you just want to introduce a bit more of yourself if you want, and then the floor is yours.
Thank you. So I am a medical oncologist. I am the chief of the Thoracic Oncologists in National Cancer Institute in Italy, which is one of the biggest comprehensive cancer center in Italy. And I live in Milano. Milano is the epicenter of the crisis in this day. And maybe you can hear also from my house the sirens of the ambulances, because the city is really full of people who have the COVID virus. And maybe you could hear also yesterday evening we had 1,000 deaths. So the situation here is really, really awful. And I just want to tell you the story of Italy, because I think that maybe you can learn from our mistakes. So the situation started that there was an alert from WHO the 31st of January. And we started to receive emails that there could be the COVID virus somewhere. But we are Italians, China was very far, so we thought that this could never happen. And it was just a chance that more or less in the 20th of February, there was in Codogno, which is a small town in the north of Italy, there was a young man. He had a terrible pneumonitis, and after 2 lines of antibiotics, the doctor decided to do the test. So we had the first test in Italy just for chance. So after that, we started to test the people in that area, which is Emilia-Romagna, is not Lombardy. And this was the first outbreak in my country. So I think that in the beginning, so first of all, we lost 1 month because we knew in the 31st of January that this could happen. And when it happened, we didn't have masks enough, we didn't have PPIs enough. So the situation was totally without a pre-plan. So this is the first point. So you must be prepared, because otherwise, if you feel in this condition, you can be in trouble. Then there was a second point that we started to think from the Chinese data that it was just a disease of elderly. Because if you see the data, only the old patients died. But the situation is not this, because the intensive care, there are a lot of young patients that go in the intensive care. About 15% of the positive patients go in the intensive care. It is true that only old people, the majority of old people, the majority of people who died are old people, but the intensive cares are full now of young people. And it is also true that this kind of young people have some comorbidities. Hypertension is the most common comorbidities, but you can see a lot of patients, maybe 50 years old, they just have a small diabetes, just one hypertension, so one very mild comorbidities, and they go in the intensive cares. So this is the big point of this virus. So you must be prepared that if you are attacked, you have to face with the need of a lot of intensive care beds. This is very, very important. So we passed in the second phase in my country where, you know, also the Italian people, they kiss each other, we hug. So we have a very social life. So it was very difficult to lock our country, also from a cultural point of view. And so in the beginning, we were divided in people thinking that the people were crazy and we had to continue our normal life, but the situation worsened day by day. So now, as you see, we are totally locked. You can go just out for the dog and for the market, but we are totally closed. So what we did in from the LT system. So first of all, we are a public LT system, so you don't have to pay to receive to receive everything. So this is very important and very different from US. So initially we started to divide COVID positive centers and COVID negative centers. And my center was a comprehensive cancer center, so it was supposed to be a negative, a COVID negative. But I can tell you that it is totally impossible to maintain a COVID negative hospital, because it is so contagious, the virus, that although if you have a lot of protection, some patients, some parents, some relatives will bring you the virus, because just maybe they go to buy the bread, they go to the market for 1 hour, they come to the hospital and they are contagious. So you must have a lot of attention to protect your hospital. And after 5 weeks, what I can suggest you is to divide one part positive and one part negative. So, and in the middle of the hospital, you must have a gray area where you can have those patients who are supposed to be positive. So you can decide if to throw them in the positive or throw them in the negative. It took, I think, 3 weeks to organize this. And so I started to send emails to friends around the world to be prepared, because if you play in advance, you have more, you don't lose the time that we have lost in Italy. The other point is that in Italy, you see that we have 9% of mortality, which is totally different from China. And this is a very important point, because we decided to test only symptomatic people. That means people with fever, 37.5 more than 37.5, cough, conjunctivitis, otitis, ageusia, dysgeusia, whatever. So, but you had to have fever. So when the mortality is so high because it is enriched by people very strongly symptomatic. So I think that it is true that it is 1% in the overall population, but it is 9% in Italy because we had we enriched the positive of people already affected by a severe situation. The other point that I think it's very important is that it is a big mistake that it was done in Italy, is that we decided to test only symptomatic doctors. And as you see, there is a huge mortality, and there is 10% of the overall positive, COVID positive, who are healthcare professionals. And this is because, you know, also from the science paper that was published 1 week ago, you know that 50% of the positive are asymptomatic. So maybe you have in your hospital COVID positive professionals that are not tested, and they can be contagious for the other healthcare professionals and can be contagious also for the patients. So in my opinion, now the hospitals are the most dirty place that we have in my city and in my region. So my suggestion is that the healthcare professionals must be tested, and must be tested many times. So maybe every 72 hours, every 5 days, I don't know what is the exact time, but you have to continue to clean the professionals and to remove the professional if they are dirty. And maybe if there is a huge discussion in Italy, because maybe if they are positive, you can use them. If they are asymptomatic, you can use them in the COVID positive places. This can be an option. And the other option is that they stay at home and they recover. This is terrible because I have a lot of friends that are now in the intensive care units. They are doctors, and all the families are positive. And this is really, I think, a tragedy for the Italian doctors and also for their families. And this happened also for in Canada when there was the SARS. So I ask you to protect your colleagues, because this is, in my opinion, is a very, very important point. The other point that maybe it's important to share with you is that we decided to delay everything. So we decided to delay follow-ups, to avoid useless visits, to start to do a sort of telemedicine with our patients. We are doing a very strong contacts with the patients by phone. So every day we try to be connected with the patients, because the patients are really worried for the cancer and for the COVID. So I think that this is very important. But I think that it is also important to underline that when we started to delay, we thought that it was a battle of 1 month, 15 days, no more. And so delaying can be very important, but I think that we have to collect the data, because it is a long-term battle. So if we continue to delay, I think that we increase the mortality for cancer. So at a certain time, we have to decide who are the patients to be treated and who are not. What we observed in our clinic, if I am too long, please stop me. I'm Italian, I'm chatting a lot. So we saw many patients, during immunotherapy positive. So in the beginning, we thought that immunotherapy could be dangerous. But the reality is that, in my opinion, we don't know. Because when we went back to our charts, the patients with on immunotherapy, we discovered them because the radiologist called us and said, okay, we have a CT scan with pneumonitis. So we have the differential diagnosis between pneumonitis and the COVID virus. So I think that this is a biased population, because if you have a patient on chemotherapy, maybe you don't check so many times if you have pneumonitis or not. So I think that the role of immunotherapy is still unclear. And the other point is, anyway, we try to delay also immunotherapy because maybe we know that the T lymphocytes are active also if you deliver the treatment after 4 weeks, 5 weeks, and not every 3 weeks, 2 weeks, according with the schedule. But after 5 weeks, we are in trouble because we don't know what to do. You can't delay every time the treatments. And what we observed, for example, is that patients with lymphopenia are more affected, and with transaminase high are more affected. Just 2 other points that, in my opinion, are very important is that you have, in particular for cancer patients, you have a category of patients who do not require the intensive care. And they can stay at home if you are able to deliver help at home with the antivirals and with the oxygen and whatever. So I think that another lesson from Italy is that you have to move from an hospital-based idea to a community-based idea, because all the people around can be very important to help the recovery of the patients. The other final point is that you have to test many times, because if you have a patient with fever and with pneumonitis, you can have 1 test negative, 2nd test negative, and the 3rd test can become positive. So when you have a pneumonitis, you must be very, 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 very careful, because the majority of them, in particular in my country, they are positive. This is more or less what I can tell you, but please tell me whatever you want. It's 5 weeks that we are fighting with this situation, and I hope to be helpful for you.
Marina, that was hard to hear, but thank you so much. Your experience and what you're doing there is just extraordinary. And you know, we have many healthcare workers on the line, and it's sort of striking all of us, you know, with the lack of PPE and testing coming a little bit late. So I'm sure there are a lot of questions for you. And I think what we'll do is, you know, we have over 250 people on the line, and I think in large part it was to hear your experience. So thank you for coming. So what I'd like to do is take some questions. There are a few in the chat room, so I'll ask the first one. Haas can ask the next, and please keep them coming. But the first is, someone said that they heard the mortality in lung cancer patients was as high as 20% when they had the COVID virus. I know you've said you've tried to keep the patients away, but have you, patients that have had COVID and lung cancer, what has been your experience?
So if you look also to the casuistics of China, the majority of patients had non-small cell lung cancer. So I don't know, again, if this is because, you know, they have breathless, they have cough. So when they say that they are breathless, maybe you overtest. So the reality is that I'm not completely sure that non-small cell lung cancer patients are more sensitive to the COVID virus. Anyway, if they get the COVID virus, they have a big problem, because they get the pneumonitis and they have problems. What I can tell you is that the majority of patients did not require intensive cares. I don't know again if this is something true or wrong, but I didn't fight with anybody to send patients in the intensive care. But anyway, we will have to manage the story of the intensive cares if the intensive care beds are not enough.
So Marina, again, thank you so much for doing this. A couple of more practical questions. For the healthcare workers who are tested positive, when do you guys decide when it's safe for them to return to patient care?
Okay, so now we do 2 tests, and only when you have 2 negative tests, they can come back to work. And we are working also on blood tests, but as you know, there are no tests very sure for on the blood. But when you have 2 negatives, you can come back to work.
How far apart are the 2 negative tests?
3 days.
3 days, great. We have a lot of good questions from the participants. I'm hoping that they will continue to come in, but let me ask you specifically, in your experience, and I don't know whether you've gone through this or not, have you noticed that patients who are on TKIs for an EGFR, let's say, a mutated non-small cell lung cancer, they're at a higher risk of having pneumonitis when they get the COVID? Do you have any data on that?
So there are no data. We have now in my clinic and also in the clinic of my friends around Lombardy, there are all types of patients. So yesterday there was one on the first line with osimertinib, but we have patients on first line tocilizumab, first line chemo plus IO. So I think that it's unclear if there is a higher risk in this population.
Are there
Marina,
go ahead.
Go ahead, Haas.
No, I was going to say, I want to hear from the other panelists if they have specific questions for Marina. So go ahead, please.
Well, I'll ask while they're raising their hand. What about treatments? Have you found any good treatment regimens here? Because certainly that's going to be key to find the right cocktail. Anything we've been reading that a lot of the drugs, some of the drugs that we use for CAR T toxicity are working here, with tocilizumab and others. Can you share your experience?
Yeah, so we are a COVID negative. So when we have a patients COVID positive, we send the patients to the COVID negative. So what I can tell you from my friends is that tocilizumab works in at least 2/3 of cases, but there are also several other drugs working in this field. You have to test the IL-6. And the other good information that in Italy, we are trying to deliver the drugs also subcutaneously. If this works, again, if your hospitals are full, maybe you can deliver the drugs in another way in the houses.
Maria,
thank you.
Are you aware of any reinfections of people who've already been infected in Italy?
So I don't know nobody who is reinfected, but as you know, there is one case that was from a medical doctor who became negative and then he became again positive. So I think that we don't know if this was just the cure of the COVID, if this was a reinfection. I think that this is again an open question.
Excellent. So,
hi.
Go ahead.
Hi, Marina. Marina, it's Brendan Stiles. We're getting a lot of questions here about new patients and how to handle throughput. How are you doing biopsies and molecular testing? And do you have any good suggestions for that in the U.S.?
So the good news is that we are continuing our clinical practice is 80%. So we were able to manage the majority of our work, and we are continuing to do our routine. So what we are delaying is maybe second line and third lines, but we are continuing to diagnose cancers and we are taking care of patients. The surgery is doing a great job, but you know that there is a huge problem if you become positive after the surgery. So you must be very careful in this part after the surgery to, because these patients are really in danger.
That is great. I think we can continue asking you questions for the rest of the day, but let's give you a little bit of a break, move on to our next topic, and then we're going to come back. We really are getting fantastic questions about what to do with chemotherapy, what to do with immunotherapy. These are all topics that we're going to try to address towards the end of the program when we open up the question and answer session. So thanks again, Dr. Garcino, for being here with us. Let's move on to our next panelists. In this section, we have two panelists who are going to share their experiences, Dr. Ann Chiang from Yale and Dr. Jeffrey Bradley, a radiation oncologist from Emory. And they're going to talk a little bit more about the practice management, things that have changed, role of radiation. So we're going to start with Dr. Chiang first for a 5-minute presentation, then we move on to Dr. Bradley, and then we'll come back and maybe we can take more questions at that time. So Dr. Chiang, please.
Great, thank you so much for having this. And thank you, Marina, for speaking and letting us know about Italy. It strikes me that as we in Connecticut are looking at New York City and what's happening there and across the divide or the ocean to Italy, there's a lot of anxiety. There's a lot of fear around what's going to happen, the worst case scenario. How do we prepare for that? And yet, how do we stay healthy and stay in the moment? And it struck me that this is actually perhaps something that our patients go through, right? So cancer patients, you know what the worst case scenario is. You are trying to prepare yourself, but every cough that you have or every symptom that you have, you're thinking, do I have recurrence or do I have COVID virus? So I think that maybe one positive aspect of this is that it may give us some insight and some empathy towards what our patients feel every day about cancer. So I wanted to speak very briefly about some of the changes that are happening in our system, in our healthcare system, and also in our management of lung cancer patients. We have in our system about 103 COVID positive patients that are hospitalized in 4 hospitals. And many of those, 166 in 4 hospitals and about 30 that are on ventilators. We are really working to decant our schedules, prevent non-essential, allow patients who don't need to come in to stay at home. Certainly we have our treatment patients coming in. Those are down probably about 10%, and our visit schedules have really gone down. So throughout Smilow Cancer Hospital, this is all multidisciplinary. In week 1, that's 3 weeks ago, we had 4,500 clinic visits. In week 2, we had 2,500 with 380 televisits. And in week 3, this past one, we had 2,300. Of those visits, 1,000 were televisits, telehealth. And of the televisits, that includes both video visits, about 500, and the other half by phone. So what I think and this is happening around the country, just a massive transformation in how we deliver our healthcare. And I think that we've always tried to deliver healthcare closer to home, but now it's actually in the home. And then finally, in the last minute, I just wanted to talk a little bit about our guidelines that we've developed as a group towards care in this crisis era. So for systemic therapy, when possible, we've gone to Q3 week or Q4 week regimens. For example, Q4 week atezo. We've decided to drop the chemo pemetrexed in a pembro maintenance, and overall in maintenance regimens, think about taking a treatment holiday. We certainly are considering neoadjuvant instead of surgery up front, and for stage 1 rapidly growing, considering surgery, but if also heavily considering non-surgery, such as SBRT or delays. We continue to try to have our tumor boards and discuss these cases in a multidisciplinary setting. You know, one of the things we've also talked about is doing first line for Pembro positive patients, doing Pembro alone. That's our trial in Cigna for Pembro alone versus combination. But I think in this case now, we're thinking that avoiding the chemotherapy may be best right now. And then finally, I think there was a question about liquid biopsies. I do think that this is something that's been very helpful. Many of you know that you can do this at home too. They will come to the patient's home. Again, doing our best to social distancing, but connect with our patients through telephone and through video visits.
Thank you so much. That was great, Dr. Cheng. We appreciate your expertise, and we're going to come back to questions again at the end. Dr. Bradley?
Hello there. I am a radiation oncologist in Atlanta, Georgia, and I was asked to talk about how we're working within the radiation oncology department, what staffing changes, telemedicine, and then to go through a few specific situations that how we've changed management for some of our patients. Basically, we're trying to reduce exposure, keep 6 foot distance between, reduce the number of faculty and staff by 50% or so, stagger shifts so that therapists don't overlap, 2 therapists per machine, giving a gap between when patients come in so they don't overlap in the waiting room or in the department. We're triaging patients. Our physicians on medical oncology and radiation oncology side are stating whether they need to see that patient urgently within the next week, if they could wait 2 to 4 weeks or push out beyond 4 weeks. We've gone to telemedicine pretty much fully for our follow-up visits. We're starting to do that for new consults for situations that you don't need to do a direct physical exam as much. Our surgeons, the surgery rooms are locked down. Basically, they're only doing emergent surgeries. So that's creating an increase in the number of some patients that we're seeing, let's say in the head and neck cancer arena or early stage lung cancer. In terms of what to do, how we've changed the radiation therapy management for some patients, we treated a patient with a growing, progressively enlarging stage 1 lung cancer, 3 centimeters with a single fraction of stereotactic radiation this week. That hasn't been our practice. We've been using either 3 or 5 fractions, but RTOG 0915 showed that 1 fraction may be just as good. So you could bring that patient in for a consult and a simulation on 1 visit and bring him in a second time for a stereotactic dose, and that patient came in twice. We've gone, like for small cell, to treat shorter number of fractions. 40 and 15 is a reasonable alternative. There's a lot of chat rooms out there in radiation oncology with people asking about different scenarios, and that's a common one for small cell lung cancer, most commonly used in Canada and UK and other places. In terms of locally advanced lung cancer, you could think about all kinds of scenarios. What would you do with an EGFR mutated or ALK mutated cancer? I could see where you might give those patients targeted therapy before bringing them back for radiation therapy. If it's a non-bulky, non-central tumor, you could use a hypofractionated radiation course. 55 and 20 is a common scenario, and give concurrent chemotherapy. We can think of a lot of different situations of what you would do, and maybe some of that will come in some questions, but those are some of the things we're thinking about.
Jeff, thank you so much. I really appreciate your input. There are a lot of questions regarding radiation and the role that it plays in various settings. And again, we are going to get to as quickly as we can. So thanks for that introduction. Let's move on. Our next panelist is Dr. Kristen Marone from Hopkins. And she will be discussing some of the challenges that are affecting staffs and our fellows, the trainees that we have in our programs. So Dr. Marone, please.
Yes, thank you so much. So I think, as we've all heard already, things are rapidly changing, and a lot of these guidelines are sort of institution specific. For us in Baltimore, we're currently seeing a significant daily increase in patients, but we're not anywhere near the rates of our colleagues in New York and Seattle and Italy. And so for us, I think at Hopkins, we're sort of in the rapid planning process and thinking about how we're going to take care of our patients sort of with our first surge. So the governor deployed this week the National Guard to work with us at Hopkins, University of Maryland, and MedStar to create a 1,400 bed hospital in the convention center downtown. But thinking about how to staff those patients with providers is sort of a big question. So for us at Hopkins, I'm the Fellowship Associate Program Director. So a lot of what I've been doing with that hat on has been focusing on our 36 clinical and research fellows, because they're going to be part of the frontline response. And I'm sure Dr. Stiles can speak to what he's been seeing in New York City. But in terms of following right now the institutional guidelines, they're working from home and they're off all their outpatient rotations and electives, and they're really just awaiting information about where they're going to be working. So while they're doing all of those things, they're continuing telemedicine for their longitudinal patients and taking overnight calls from our outpatient cancer center. We've created a Jeopardy system to back up all of our inpatient services. So at our cancer center, it's about an 80-bed inpatient service across the different solid tumor and hematologic malignancies. And so our fellows will be a big part of the deployment across those services. Just speaking as a thoracic oncology faculty, we've also created a coverage schedule. So I think this is probably very institution specific, but for us, just to decrease exposure, as we were saying, we actually work at 2 campuses, so we don't want to be going back and forth throughout the week. We have a faculty member seeing all of our patients within our group at a given day and time. And then the primary longitudinal faculty are transitioning the majority of our visits over to telemedicine and sort of figuring out how to space out and decouple imaging from visits is what we're working on as a group. The other thing is just thinking about our new patients and doing telemedicine where we can, because I think state requirements are changing by the day. So we've been trying to increase that as much as we can, just with the goal of minimizing patients having to come in to the cancer center. From a trainee perspective, our GME office is working right now on looking at the trainees across the institution and how to redeploy them in waves or tiers into the different services. And so, our anesthesia trainees are now the code team so that more internal medicine colleagues can be focusing on the COVID patients. So I think the other big thing just to think about is looking at how to do just-in-time training and training up our colleagues to get them thinking about inpatient critical care, because all of our trainees want to be focusing on oncology right now. And so how to balance that is something that we're dealing with. So we're working on communication and thinking about how to get everybody to know where they should be at a given time, and thinking about keeping themselves and their families safe, like in Italy, and things of that nature. So I'll let the next person talk so that we can keep going.
Thank you.
Thank you, Christian. That was great. So now we have 2 perspectives. And we heard from Marina that, you want to separate COVID from non-COVID if you can. And so we're going to hear from one person who's at a freestanding cancer center. And then we'll hear from Brendan Stiles, who's at New York Hospital, right in the center of things. So Marty, can you give us a little bit about how you're preparing at your center? You must have a lot of transplant patients there and a whole bunch of immunocompromised people.
Yeah, so we're in, I think, somewhat of a almost unique situation. Fox Chase is one of the original, NCI designated centers, is freestanding. We have a 100-bed inpatient hospital, which is exclusively cancer. So we're not in this situation in the past of running an ER or managing, general medicine. We are physically connected and adjacent to Gene's Hospital, which is another part of the Temple University Health System, where it is general medicine and where also our transplant service is located. So what we have done is we've built a collaboration with them where we will be the COVID-free facility and they will be the place where COVID patients will be hospitalized, with the exception of isolating the transplant center, which is BMT, to which has already significantly decreased the number of transplants and are just down to the most critical patients. So what we are doing is any patient who comes externally and would have been seen in, say, an urgent basis in our kind of urgent care part of Fox Chase is being seen instead at Genes, and will be seen there, assessed for COVID. Will be done if it's pain or fever or whatever, assessed there, and then would only, if they need inpatient care, would only be transferred to Fox Chase with a negative COVID-19 test. So that's kind of the very big picture. We are the flip side of that is we will be taking general medicine patients for the first time, and have, of course, to increase our coverage for that. So relative to what was just said, our fellows are being mobilized to provide some of that general medicine coverage. It is interesting that ACGME has declared a national emergency and or allowing individual institutions to declare an emergency, which suspends the educational requirements. And I believe that that's institution by institution. The only thing is the highly sacred work hours. I think as the aliens invade, we will still have our 80-hour work week. That is, just sacrosanct. I have to admit, having come out of the United States Navy, I find this highly amusing. That's kind of one of our, our initial approach to this. We've also switched a great deal to telehealth. I think that works potentially quite well with survivorship care, with routine toxicity checks, et cetera. I am quite concerned. I'd be very interested in what others have to say about this for new patients. I think we're very different than, many situations, certainly not all of them in surgery or radiation, where, the assessment is for really episodic care. Are you going to do this specific radiation treatment? Are you going to have a surgical procedure? When we're being asked in many cases is to see a patient with advanced cancer who will require long, not only treatment with drugs that on a good day have a low therapeutic index, but also prescription for their narcotics and solving all their other symptomatic issues. And those decisions, I think, do require a certain, a complete history, physical, and that type of assessment, at least at the beginning, to begin to establish this. I think one of the other big issues that we've had is we've severely restricted the number of individuals that can accompany patients, essentially eliminated it from any visits to the hospital, accompaniment in the infusion center, as well as, to visits, including initial visits, though there we have a little bit of leeway. And, again, I think that that's somewhat problematic. These are, the cancers are not taking a break or going to sleep during this epidemic. And I think that, we could potentially lose the opportunity to treat patients who will suffer a very high mortality and more rapid onset of problems from their malignancy than from COVID-19. So I think it's a very difficult balancing act, and I think what's made this a particularly stressful time, as everybody else has mentioned, is the rules change. There is no routine anymore. You get up in the morning and all your assumptions are out the window, and then they keep changing, by the time you get into work, and then they get thrown out again around noon. And it's that constantly changing situation that I think contributes to this stress.
Thanks, Marty. That was very, very helpful. That the government, the ACGME, has been pretty flexible to allow us to repurpose many of our trainees, but they are pretty strict about those 80 work hours. And we should have a restriction on the number of Zoom hours all of these senior oncologists have to do.
Yeah, the number of publications.
but it is nice that we're, people are in town and working, and it's really all hands on deck. So thank you for that. Now, Brendan, we're very happy. Brendan, he's a surgeon, so it's good to have a surgical perspective here. Yeah, you just mentioned, think of all the people who are missing their surgeries because they can't get them right now. But also, he's at New York Hospital, which is just 80 miles from where I sit. But I know it's a very hotbed of disease, looking a little bit like Italy. So, Brendan, we'd love to hear your experience.
Yeah, well, I'd love to share it. Thanks for inviting me. I think as I sit and listen to everybody else, we're going through a lot of similar things, particularly what Dr. Garasino described in Italy. I think we really are seeing in New York. The cases went over 26,000 yesterday, and we're really at the epicenter of this. It's really been a huge strain on all the hospitals in New York. New York Presbyterian has well over 1,000 patients with COVID. At my institution, there's over 150, of which a third are ventilated. So it's a real deal, and it's making an incredible strain on our ability to provide cancer care. Our leadership at New York Presbyterian has responded incredibly well, and I think we're really trying to stay out in front of this, but as others have alluded to, it's very much of a moving target. Lung cancer surgery has really ground largely to a halt. I think we're only doing a handful of selective cases, and I suspect that in the next couple of weeks that may shut down completely. A great example, a case I did last week was a lady with obvious local progression, who was very healthy, actually got out of the hospital on post-op day 1 after lobectomy. But we found out just through the journey of her hospitalization, she came in contact with another COVID-positive patient. So you can imagine all the perils that are there for these mixed population hospitals. And I agree with Dr. Garasino that it's impossible to split off the COVID patients and the non-COVID patients because we are seeing a lot of asymptomatic carriers. Same applies for healthcare providers. We had an intern on our service go home earlier this week after testing positive. And sort of how the hospital deals with that is constantly a moving target. I would not want to be a hospital administrator now. These folks are working so hard and really balancing so many things. At our hospital, we're pretty much shut down elective surgery, except for urgent cancer cases and urgent cardiothoracic cases and others. I suspect that will continue to decrease. We've really mobilized our ICU resources. As I mentioned, we've got a lot of patients on ventilators. We converted our cardiothoracic ICU now to a full COVID unit. We moved out of there into another PACU. Hospitals are sort of figuring out where we can best put those resources and get extra ventilators. Researchers at Columbia are trying to work on splitting ventilators, which has been in the news a lot. We're trying to use our operating rooms as ICUs and trying to figure out how best to do that. The staff at New York Presbyterian and Cornell have done a great job. We've been redeploying a lot of people, and we just got another notice this week that we'll continue to redeploy, whether it's for ICU care, outpatient care, or telehealth. And I think that will be an important part of everybody pulling together and figuring out how to do it safely. Like others, we've limited hospital visitors, even for everything, essentially, even for outpatient visits, for maternity. If you have a baby, you have to do it on your own, and it's an incredible burden, but we think it's the right thing, and we think it's really important. Other unique aspects of cardiothoracic surgery that we're talking about are now we're starting to face decisions about tracheostomy, ECMO, and the hospital administration is sort of wrestling with how we should deal with these issues. I think fortunately at Cornell, at least, we've extubated more patients, I think, than have died. So we think we're having some success with a lot of strategies to take care of these patients well. But we're going to face an overwhelming issue of disposition. What do we do with these patients as they're recovering slowly? Where can we get them where we can take care of them safely, or we can move them out of the critical care unit so that we can get sicker patients in there? And it's a handful. It's a lot of things to deal with. At the same time, our clinical trials have ground to a halt. Our research has ground to a halt. And how that's going to affect us over the long term and affect our patients, we're struggling as an academic institution with what to do with that. And I will echo the other thing that Dr. Garasino said. I saw the New York statistics yesterday. Although certainly it's overwhelmingly older patients who are being hospitalized. In New York, I think 44% of patients with COVID are in the 18 to 44-year-old age group. And so, this idea about distancing and sort of careful hygiene and protection, I think, is really important. Those patients may not get sick, but they're certainly going to be carriers to the patients who are sick. So I continue to emphasize, I think a lot of cities are going to follow, hopefully not be as bad as New York, which is so densely populated, but everything you can do to stay ahead of this, I think, is well deserved.
Thank you so much. I think we would love to hear more about strategies that leads to more extubations and less death, obviously. So hopefully we'll come back to that. Our last panelist is Dr. Corey Langer from Abramson Cancer Center, University of Pennsylvania. He is going to tell us a little bit about what you just mentioned, Brendan, about clinical trials and how it's impacting accrual activation. And then we're going to start the Q&A. And then just a quick reminder, the program is being recorded. I've had some messages that unfortunately some people missed the beginning of this program. We will provide information as to how to access the recording. So with that, Dr. Corey Langer, please.
Thank you, Haas and Marty, and all the other panelists. Needless to say, clinical trials is a luxury that the current situation really can't completely afford. With one or two exceptions, accrual, for the most part, and I'm sure this is true for the rest of the country and probably the rest of the world, is ground to a halt. We have certain critical trials where the treatment is clearly better than standard, which we are keeping open on a case-by-case basis, and those who have already been worked up for trials are about to enroll. We're proceeding with that. We've learned very quickly, as I'm sure most of you realize, that a lot of clinical trial visits are completely gratuitous and superfluous, day 15 physical exam only visits that really have no bearing on either the integrity of the trial or the well-being of the patient. We have converted those to telehealth with the blessing of our IRB and the blessing of much of industry on a, again, trial-by-trial basis. I think this is going to radically alter in the future how we conduct clinical trials and how we really hone in on the essentials, not the picayune details that drive our clinical research coordinators mad and ultimately have no bearing on clinical trial outcome. Speaking personally, regarding the clinical trials unit, we are minimizing the presence of just about everyone in the institution. There is one clinical trial nurse per day. They are alternating, they are covering each other. One coordinator per day. This is for a team of 8 or 9 people. Virtually all are working from home, by email, by Zoom, by phone. Again, pretty much mirroring the experience of all others involved in clinical trials work. From a broader picture, and this really pertains to a broader academic institution that sees all kinds of patients in Philadelphia, so very different from Fox Chase. Philadelphia may potentially be benefiting from the physical distancing that has been enacted over the last 2 weeks. The entire city, as of yesterday, had just over 500 documented cases of COVID positive. I believe that is maybe 1/60th the incidence of New York City, in a city that has roughly 1/5 the population. So as a system, although we've converted separate units to COVID positive, fortunately they are not yet populated. As of late last night, we had just under 100 COVID positive patients in 5 separate affiliated institutions, NPenn less than 25 on ventilators. Princeton Medical Center, which is part of our group, actually has the plurality of these patients. Princeton is a ring suburb of New York City, and you can draw a radius from the center of New York City outward and see the number of cases and how it sort of declines with further distance. So we may be seeing some benefit ultimately, hopefully, in flattening the curve, reducing mortality, and conserving vital resources. Finally, all healthcare workers who come into the institution have infrared temperature testing. They will not enter the doors if they have a fever. Not sure what to do for people like me who usually run low temperatures. So for me, 98.8 or 99 might actually be a fever. But anybody exhibiting symptoms, of course, is cordoned off. The outpatient area is completely cordoned from the inpatient area. It's as if they're 2 separate institutions. There are absolutely no visitors, no accompanying family members for outpatients. We're doing a lot of FaceTime with family members in the waiting room or at home, and absolutely no visitors for inpatients. And our census, which is usually running 110%, is now down to about 65 or 70%, at least at HUP. Our new patient visits are almost entirely telehealth. Again, with the exception of physical exam, and even to some extent that, You can do everything on Zoom or Blue Jeans is one of the networks that we're using, and of course, gather all the family around in the comfort of their dining rooms or kitchens and discuss what to do. I agree with Marty, we do need to examine these patients at some point, but perhaps not repeatedly. So this remote delivery of medical care, both by telehealth and video health, will, without question, after this is over, and God willing it'll be over sooner than later, will revolutionize how we practice medicine, particularly how we practice oncology.
Great, thank you very much. Appreciate everybody's input. We have a lot of really good questions. So first of all, for those panelists who can stay on, we sort of think that we might go a little bit beyond the 11:30. So if you can, please stay on, because we have a lot of really good questions. There's a lot of needs, but if you cannot, then we understand, and that's fine. So we are now going to go through the questions that we have gotten and try to provide some answers. I do have to give shout outs to a number of really national, international experts who are on this program right now. Dr. Hubrugo, even though she is not a thoracic oncologist, she is one of the panelists submitting questions, listening, trying to expand the knowledge that we all have about this. So thank you, Dr. Ramalingam, Dr. Bramer, Dr. Rohit Kumar. They're all online submitting really important questions. If I miss your names, I'm sorry, but these are the names that I recognize. So I just wanted to give a shout out to all of you for helping us make this program more meaningful. Let me start with the first question that everybody is asking, and this goes to Dr. Bradley, and perhaps Dr. Edelman can respond to this. What do we do with patients with locally advanced non-small cell lung cancer? How do we manage concurrent chemo and radiotherapy? Please make sure you're not muted, because a lot of your screens show that you're muted right now. So let's start with Dr. Bradley regarding management of patients with locally advanced disease. How would you approach it?
That's a great question. And we all know that that's a very, very heterogeneous population of patients. You have some with a peripheral lung nodule and a mediastinal node that are asymptomatic. I can envision you give that patient chemotherapy or systemic therapy and wait for radiation therapy. You have others that may have T4 disease or symptomatic. They have obstructive symptoms that you may want to give concurrent chemoradiation. In those situations, you might consider some sort of hypofractionation regimen. Then you can get off into whether, you know, they have a targetable mutation. Might they respond to an EGFR drug, et cetera. So I think it's a very individualized situation you have to consider for each patient. I don't know, Marty, you want to comment?
Okay.
Marty?
So yeah, I'm sorry. I just took a second to unmute. I'm still figuring all this out. I agree with Jeff. You know, this is a very complex situation. Like with everything else, I think it needs to be individualized. And you know, I think probably the most crucial thing is to sort of decrease the number of touches for the patient and not lose one's opportunity for cure. And remember that in stage 3 disease, it is a potentially curative treatment. So I think the possibility of doing induction chemotherapy, perhaps even chemoimmunotherapy, that would buy us 3 or 6 weeks or longer. Let's face it, if let's say somebody gets treated you know, next Monday, then it's 3 weeks from there, and then, you know, get 2 to 4 courses, we could potentially push out their need for radiation or concurrent chemoradiation a couple of months, when hopefully this will have crested and be receding as an issue, and then they can get, you know, perhaps standard radiation. There are certainly well-published experiences, particularly that from Anderson, of doing you know, more hypofractionated approaches to preserve the idea of doing chemo radiotherapy. And you know, I would not hesitate to continue to utilize consolidation immunotherapy, but perhaps instead of every 2 weeks, you know, there's no real rational reason not to give it, say, every 4-week durvalumab, and do that with the patient, you know, after having had an assessment that they did not have any progression during their chemoradiotherapy, you know, doing telehealth visits in that situation, and stretching it out and not seeing that patient very frequently, you know, other than the telehealth visits. So, I think the key to all of this is to decrease the number of interactions with the system and not to overburden things like surgery or radiation and at this time.
Thanks, Marty. So we have dozens of questions. Let me just frame one that seems to be coming up a lot, and that's who to test, when to test, and it involves both patients and healthcare workers. So the first is, should we screen patients for COVID before we treat them? So if we do have to give chemotherapy or some other immunotherapy, should we screen them? I know in the bone marrow unit, patients are being screened, but what about lung cancer patients? Who wants to answer that? Why don't we get Marina first from Italy, and then if one of the other panelists can raise his or her hand, we'll call on you next. Marina?
Yeah. So we addressed this issue several times because in the beginning we wanted to test before starting chemo or starting every treatment. But at the end we decided only to test the patients for surgery, because you can be negative and 3 days after you can go to the market and become positive. So we are very careful with the fever, with the cough, with the symptoms, and we test, we do more CT scans maybe, but we do not test before chemo because maybe you can become positive just 3 days after. It's a pragmatic.
Thank you.
I don't know if it is right or wrong.
Let me ask Hope Rugo from San Francisco. I see her picture there, my old friend. Hope, it's good to have you. What are you doing in UCSF?
Well, they just actually, yeah, they just instituted a policy for healthcare providers to wear masks in any healthcare area. You get 1 mask a day unless it gets wet or you have exposure, which is the CDC guidelines. And I think that that's an interesting thing. I think it actually may make our patients feel a little bit more comfortable. In terms of screening, there has been a call to screen patients before surgery. And I think that as Marina mentioned, I think that plays a role in many ways, including keeping our ventilators as clean as possible. There's just protecting everybody from patient to providers. It's just that until now, the testing hasn't been available. But as was mentioned earlier on this call, I think that testing is really expanding and the rapidity of results is really expanding. So I think as providers, we should push for screening. And the other place I've heard for screening is before bone marrow transplant. So they're routinely screening patients who are coming in for bone marrow transplants, which seems like a really good idea. We're only screening otherwise following the CDC recommendations. The other thing I thought was interesting that Maria mentioned was screening for healthcare providers every few days. We aren't doing that. I don't think anybody else is.
Yeah, that was going to be my second question. So given that what we heard, Marina, are you screening the healthcare workers? We should be screening everyone every day on the way in the hospital, symptomatic or asymptomatic, based on your experience.
So this is a very bad story from Italy because the politicians were worried that if all the doctors became positive, there were no more doctors in the hospitals. So now they are testing only symptomatic doctors with fever and cough and with other symptoms. So they do not test all the asymptomatics. I think that this is very wrong and very dangerous.
Yeah, I think we have nosocomial spread. Who else wants to answer this?
I'd love
maybe
to.
Brendan, just raise your hand.
I did. I would love to come in with us too.
Brendan.
Very important. Can you hear me?
Yes.
Yeah.
I think it's very important to test surgery patients. There's such a risk of aerosolization during the procedures and such a risk to our anesthesia colleagues, as well as issues with the ventilators, that I think we should be testing. I hear we're moving more and more towards that type of a model. We too are not testing all of our physicians, and as others have said, there will be a lot of asymptomatic carriers. We have instituted a mask policy and we're going to a face shield policy as of the end of the week. And I think certainly protecting our patients from potential carriers is important. How we sort of staff the hospital is also important. And so we're working through all of those issues.
So this is Marty. I mean, I think that right now there's just not the bandwidth to test all the providers, as people have said, there are limitations on swabs, media, et cetera. Now, I think that, the situation for providers and patients and who we test is going to change rather rapidly if, one, that 4 or 5 hour test comes online, number one, and number two, if there's adequate materials. We've gone, the basic policy, every patient that's examined, the physicians are wearing a mask with a face shield preferably and gloves. So, that's, and most of the patients actually are given masks on the way in. So that's, I think, potentially helping to prevent spread within the institution.
So, Marty, are you having all patients be masked, or all the physicians and providers, or both?
Pretty much, it's well, certainly all physicians in examining the patients are in fact, and all providers, this includes the nurses in the infusion area, which is probably one of the biggest pain points, and potential areas for spread. We haven't really touched on that, but certainly all the physicians are masked and gloved, and I see increasingly the patients are, and I think we'll just go and having all of them masked as well. Infusion areas are open spaces, and it was interesting. So about a week ago, I walked around the hallways of Fox Chase. You could have shot a cannon down the clinics without coming near to hurting anyone, and walked into the infusion center, which still looked like the New York subway on Friday afternoon at rush hour. And so since that time, what we've done is, spread out the patients there. We're looking to try to move low-risk infusions like, your, cycle 12 of durvalumab, to rooms which might have less supervision but will be more isolated. And then there's this, multiple levels. All patients, everyone coming in the hospital is being screened.
Great, guys. This, again, a wonderful discussion. Dr. Owunakuku, I'm wondering if you can address a couple of questions. We're going to start with you and again open it up to everybody to participate. That has to do with the role of chemotherapy. First of all, in the curative intent setting, somebody has had surgery. What do we do? What are our recommendations, whether patients are COVID positive or negative, and how that might impact us? The other question obviously has to do with, again, procedures and biopsies. If somebody is on a clinical trial that mandates another biopsy, are we doing that? Are we recommending that? Or are we going to the sponsors and saying, look, we need to sort of avoid unnecessary exposures? So we've had a number of questions about the role of chemotherapy in general. You can just briefly talk about that, and we get the opinion of other panelists too.
Yeah, I think the role of chemotherapy or any other immune suppressive interventions at this point, we have to balance potential long-term benefits versus very short-term, real short-term risk. And where I think we have to draw the line is how important is that adjuvant chemotherapy to the patient. We know that for most of our patients, if we can delay chemotherapy and still get it started within a 3-month window from the end of surgery, that will still be consistent with the way most of the clinical trials have been conducted. So I think we have the opportunity here to not rush to adjuvant chemotherapy. If we can delay that a little bit, stay within that 3-month window, and then still be able to preserve that long-term benefit for patients. Where I think we have to possibly recalibrate is in those, indeterminate population where we've all sort of gone out to do it, like our stage 1B, N0, T size greater than 4 centimeters, where we feel, well, retrospective analysis supported potential benefits. I think we actually have to lean a little bit away from doing that during this crisis, and when everything settles down, we can start having that discussion again. That would be my general approach. I don't think we can completely throw out chemotherapy out the window because of the short-term risk and then lose the long-term benefits for patients. With regards to biopsies on trials, and I think Dr. Lenga mentioned this as well, we've actually seen very, very supportive attitude from sponsors where we're doing correlative science and we want mandatory biopsies. They've been very cooperative in waiving that requirement, especially if you have archival tissue that can still help, maybe not as good as fresh biopsies. And for our own institutional investigator-initiated studies, we've just gone away from research biopsies that do not contribute to immediate treatment of patients.
Thanks. I'll just remind you, my colleague Dan Baffa reminded me that there was a Yale study that showed you could wait 4 months for adjuvant chemotherapy. So thank you, Dr. Baffa. Okay, the next question is a really tough one. I know we have a large crowd, and this is a hard topic to discuss, but we have to discuss it, and that's about the availability of ventilators. And you know, we have patients with lung cancer, and I recall I've been doing this, you know, not quite as long as Corey, but there was a time when if you had a patient with lung cancer, it was hard to make a case for the MICU. Now, of course, with all of our therapies, targeted therapy, immunotherapy, all the surgical and radiation approaches, our patients will do quite well. We have to be advocates for our patients, but you know, it sounds like, you know, and for those centers that aren't busy yet, just wait. You know, we have to socially distance. It's happening in Connecticut every day. The numbers are rising at my hospital. So the question for you, Marina, first, and then I want to go around the horn, is how did you do it? How did you advocate for your patients? How are they making these very tough decisions, which sadly, I guess, had to be done, or hopefully not too many?
What we do is, first of all, to be pragmatic. So the situation here in Milano is that there are no more spaces for the population. So if you have a patient with a good prognosis, first line ALK positive, first line EGFR mutants, or so we go and we discuss with the intensive care units. But I think that in Italy, there is really no space for third lines, for other types of people, unfortunately. So I think that the only thing that we can do is about prevention and not to expose these patients so much. Because I hope that you will never live what we are living in Italy, but you can be in the situation to decide who is for the ventilation and who is not for the ventilation. So the cases that I had, for example, they were in the CPAP, and we decided that they need invasive ventilation. They didn't go to the ventilation.
Brendan, what about New York Hospital? How are you handling that? It sounds like it's very important that the oncologists and the primary team remain involved to help the ICU team with these decisions, and the families that can't even visit.
Yeah, I think very much so. I think Janet Freeman Daly is on as an attendee, and she's been sending out some questions. It's hard to imagine being a lung cancer patient, particularly with stage 4 disease, and just wondering what your fate is going to be if you go into a hospital. I'm sure that everybody on the line appreciates that, but really we should stop and think about these patients who are just so anxious that something's going to happen and that they're going to get care withheld or withdrawn because they're a lung cancer patient. Now is definitely the time for us to push back about the nihilism that's associated with lung cancer. And I think we're going to have to be individual advocates for our patients. Clearly, some are going to be in the progressing stage and not have as good of outlook, but we know that there's many stage 4 lung cancer patients who we will expect to do well. We haven't had to bridge that issue yet at New York Presbyterian. We still have a reasonable number of ventilators left because of really leadership and plans that the administration has made, but we're starting to discuss the possibility. And I think it's going to be some really challenging questions and issues. And I know everybody here will advocate for their patients. And I hope that, we're just going to have to do that and take it on a case-by-case basis, but at the same time have some overriding guidelines.
Right. I'm going to turn to Corey in a second. I'll just share my experience. So at Yale, again, thanks to amazing leadership, we moved our cancer patients to a separate hospital. We have another hospital in town. Not an easy thing to do, so that we could make 2 more floors for ventilators should we need it. Then, of course, come all the issues of who's going to man those ventilators, and we now have no house staff on our medical oncology service, so our fellows and attendings are doing that work. But it's really, I think we're all seeing this. And Corey, what are you doing in Philadelphia? You speak for the general Philadelphia region.
Well, I think these extremely difficult end-of-life discussions that everyone's bringing up really need to happen way ahead of time, that the parameters are set and that the goals of care are established. Many patients are quite clear on just how far they want to go. And I agree with Marina, when we get down to third or fourth line treatment, if the patient's deteriorating, it would be a very difficult issue to deal with at the moment, particularly when folks who may be more salvageable are deprived of the use of a ventilator. We are, as I said, we have separated out. Penn consists of about 8 separate buildings, so you can sort of make COVID negative, COVID positive areas without moving to a completely different institution. There's talk of opening up a closed hospital, Hahnemann, to accommodate the overflows that would occur. But the allocation of ventilators, at least right now, for the moment, is not an issue. And hopefully if we can flatten the curve, that will remain the case.
Great. So I think we're talking about a lot of very important issues here right now, but to touch on this again, I think we've briefly brought it up, but not directly. Dr. Garracino, I'm going to come back to you a little bit. A number of the panelists and some questions that we've gotten has to do with end-of-life discussion, especially in patients with incurable diseases. Again, if you can talk a little bit more about your experience about how you approach those kinds of discussions in this time, I think that would be good for our the participants who ask these questions.
So the situation is that patients are much better than the citizens, and maybe also they are much better than the doctors. So they are resilient and they understand. So I think that they are with us. They know that we are doing all what we can for them. And so we try to explain the situation. We give them all the support that we can. And I think that this is a very hard part and touchy part of these days, because they are very with us.
Marty or Corey, do you want to add anything else to this? Jeff, you've been quiet a little bit. Do you have any other comments that you want to add here?
So, you know, this is Marty. I think that as Corey put it, I think you need to have an early discussion of prognosis with every patient. You know, I've always believed that it actually became a little bit more difficult the last few years as we had, you know, really the possibility of, you know, relatively long-term survival for many of our patients. But clearly, once patients are, you know, beyond their, you know, second line of treatment, their opportunity for long-term survival is for the most part, you know, rather minimal, unless they're, you know, we all know of specific situations, oligomets, et cetera. I think that, you know, we have to be advocates for the appropriate patients, but not the inappropriate ones. So, you know, the patient who's, quote, stage 4 because they had one metastasis that got SBRT a year ago, and is otherwise doing very well, is in a very different situation than the person who's, you know, has widely metastatic disease. And I think we have to be very realistic and appropriate with our colleagues as far as, you know, who will likely benefit from ventilatory support. I mean, this is essentially becoming a mass casualty situation, and, you know, this requires very, you know, hard decisions and the ability to sometimes make them quite rapidly. You know, I think in many ways, the surgeons who are, you know, take ATLS are much better equipped, advanced trauma life support courses, and, you know, and those who had military experience are frequently better equipped for this situation than many others.
This is a very real situation at home this week. I got a call from a daughter of a patient who was admitted. She had a brainstem metastasis that we had treated. Her mother was admitted to the hospital. She couldn't go in because all visitors are restricted. And I think we have to remember as hospital staff and doctors that we need to keep communicating with these families. They can't see their loved ones. And so we went to see her, opened up FaceTime, and, you know, had a discussion. And I just think there needs to be more of that. And we need to keep that in mind.
I think it's important. Say something?
Can I make a point on this. You know, I think it's also communication with the other teams, taking care of the patients. All of our disease teams at Yale have really gone through the process of looking at, and it's very sobering, thinking about, you know, their patient's prognosis warranting critical care, and really sort of thinking about if patients have a prognosis of over a year. For lung cancer patients, it's really those patients with early stage or locally advanced non-small cell, small cell carcinoid or thymoma. But for metastatic patients, patients who are having ongoing response to checkpoint inhibitors, patients with targetable alterations, and ongoing response to those targeted therapies and some indolent disease. So I think going through that, as Corey, you said, thinking about it, some criteria beforehand with your team, making sure that you communicate that to the team, other folks. And so what we've asked everybody to do is to make sure and document that in their last notes in Epic, so that it's very clear and folks don't say, well, you've got lung cancer and that's point against you.
Okay, so
I think it's crucially important to combat the therapeutic nihilism that still exists amongst many of our colleagues. That stage 4 recurrent label is sort of the scarlet letter for many of our patients, a stigma. And if a patient is doing well, either with oligometastatic disease or has responded beautifully, 90% response, that patient should not be abandoned. I think we really have to weigh in their current status from the cancer as we make these decisions.
Absolutely agree. That's a great statement.
Okay, so it's that time, but I think what we'll do is we'll go 15 minutes more, no more. This is going so well, and I'm learning so much. We'll do something similar next Saturday, so stay tuned. But what I'd like to do now is I'll ask a question, Hans will ask a question, and then we'll go around the panel and get some final thoughts. Now, you can put your questions into the chat room, the Q&A, and the panelists are all reading that, and then they'll take into account your questions in their area that they focused on for those final thoughts. I notice as I go through the participants, and by the way, we have 270 people still on, or something to that effect, that there are a lot of industry people on. And a lot of them are asking, what can we do? How can we help? You know, I know a lot of clinical trials are closed right now. There are a lot of physicians in industry who, you know, we could bring in if we need them, God forbid. But what about, how can industry help now? Can they provide drugs, trials, money? I'm going to ask you this, Kurt, but why don't we start with, actually, Kurt, why don't you start? How can industry help you if you're developing tests and you do a lot of collaborations, I know, as we work together?
Yeah, so it's a great question. I think the first thing that is happening is that industry is pumping into the testing. I think this is a very important point. We talk about how frequent the testing should be and so on. And we have garnered a lot of success. You know, over the last week, there have been a couple of tests approved that have these microfluidic devices. They can do testing in less than an hour. And today, actually, we heard from another isothermal microfluidic device that can test in 15 to 20 minutes. So I think testing will ramp up, and that's a major contribution from the industry side. I think the other big component that we have heard already is in the context of clinical trials. We have been waiving biopsies and some testing requirements from patients to actually deliver the care. And we know that for patients with cancer, the clinical trial is a big part of the patient management. So I think those are two important supports that we are already receiving from the industry side. And I think we should probably keep following with them.
What do you think, Corey?
Can I ask a quick question for the testing? This is Hope. The use
sure,
of
Hope.
swab.
Thank you.
Thanks. The use of swabs has been a big issue because there aren't enough. What tests are coming up that will avoid the need for swabs? And if there is a discordance, who should be retested?
Yeah, so it's a great question. We don't have great answers at this point. To the first question, there are at least 2 devices that have been already approved under emergency FDA rules that don't need to take swabs in the more traditional way. They can actually work with other specimens, even dry specimens. They go directly into the device to do the nucleic acid extraction. So that's, to some extent, being figured out. In particular, there is one platform that is a point of care device. So actually it doesn't need to have samples being transported, and that also releases a lot of the requirements. So I think there's a lot going on in that, and we'll probably will see better testing over the few next weeks that require less materials and less swabbing and less systems. There is actually a lot going on with saliva, and that's an important point because saliva testing will eliminate some of that. So we are already in that stage and we'll get better. Relative to the second point, the retesting, today, as I pointed out, there are a number of tests, and a little over 20 approved, but they use different primers. And with few studies, because there aren't very many patients out there still, it's shown that about 10 to 15% of cases can have discordant results, meaning that they either don't recognize or they can cross-react with some coronaviruses, and that's depending on the area of the gene being targeted. I think at this point, the retesting needs to be on a continuous basis, and that's a little bit what we heard from Italy, where having sort of permanent testing is probably the way to go until we see what the best sensitivity and specificity is. But I think we're going to see a certain degree of the variation relative to the different primers.
Great. What about Tafik or Corey, industry? How could they help? You want some drugs, some trials?
So I think
industry needs to make sure that the
go ahead.
My fault.
Go ahead,
Tafik and then Corey. Tafik first. Sorry.
Oh,
My
okay.
fault.
Yeah, thanks. I think there is actually a lot that industry can help with. One thing that comes to mind, which is real life experience, is with the patient in terms of patient assistance program. I know we have some of these programs where you have to have the patient coming into the office to sign documents. So if there is a way to change the rules around all these requirements, I think that is something that will be directly impactful. The second area in terms of industry, not so much pharmaceuticals, but actually thinking of insurance. And I see that Dr. Ramalinga was polling some people on Twitter. What can we do about pre-search? We're already cutting back on testing, on treatment for patients. Is there a way for the health insurance companies to sort of relax these rules about making us go through this pre-certification for drugs, for imaging and things like that? I think these are important areas that we need to look into during this crisis.
probably the most critical thing that needs to be done is to make sure that supply lines of these agents that we typically use do not fall by the wayside. So the continued manufacture and delivery is something that I would hope industry is focusing on. I agree with Tafik that we go through a lot of rigmarole in the US that's not done in the rest of the world in terms of pre-certs, and I think the insurance companies need to minimize the unnecessary kabuki dance that we typically go through, and certainly industry may be able to help facilitate that. And we're clearly seeing stretching out treatments. People on maintenance, PEM or PEM and Pembro, at a year, there's no reason we continue every 3 weeks. We can stretch it to 4 weeks, and if it's Pembro alone, there are certainly those that have advocated stretching it to 5 or 6 weeks. So the use of these agents will, I think, be radically revisited and reconsidered once the pandemic subsides.
Yeah, I see Dr. Graziano had a comment.
Yeah, go ahead.
Marina, you had a comment about how industry can help?
Yeah, so maybe one thing that can be important is to deliver at home the tyrosine kinase inhibitors, because you can check the blood exams at home with the telemedicine and they avoid to come to the hospital. This is an idea.
Yeah, I agree. I think these are all really good recommendations that we hope our colleagues in the industry will take to heart and work with us, because this is not going to be a short-term problem. I think we're going to, unfortunately, be dealing with this issue for quite some time to come. God bless you, Dr. Herbst. I think the other issue for the industry is, first of all, we're facing drug shortages already. So if that can be addressed rather immediately, especially drugs that we could be needing, that would be fantastic. And also, contributing or distributing or donating personal protective equipment, especially to areas that are in need, is going to be significant help. I mean, I was just watching the news last night, and there are nurses in New York who were saying that, you know, they get one mask every few days, and I think this is just totally unacceptable. So anything that industry can do to help eliminate some of these deficiencies is going to be significantly helpful, and they have the means to do it. I'm going to go back to one more management question that has been asked by a number of people who have participated, and that has to do with the use of immunotherapy and whether the use of immunotherapeutic drugs actually lead to worsening outcomes or worsening symptoms for patients who are COVID positive. So I'd like to get Dr. Garasino's input, but also I'd like to ask Dr. Marone if she has had some experiences at Hopkins dealing with immunotherapy, because I know they're one of the major centers for immunotherapy. So maybe Dr. Garasino can start, and then we go to Dr. Marone about her experiences. So, Marina?
So the answer is that we don't know. So I think that doing a registry is the most relevant issue at this moment, because we have to have this answer very soon, because if the virus will live with us for a long time, we can't continue to delay everything. So I think that to collect the patients is a major goal in these days. And we created a registry called TerraVolt that, in my opinion, if we are all together, we can have this answer very soon. So what we are pragmatically doing is to delay 1 week, 2 weeks, 3 weeks, because we know that the T lymphocytes can last. But the answer is that we don't know.
Okay. Dr. Marone?
Yep, and just to echo that, there is a registry looking at cancer patients that contract COVID-19, and one of the components of that will be looking at what treatments they are on. So I think as many institutions that can join that will be really helpful. From our experience with immunotherapy, Dr. Drushka Naidu helps lead our immunotherapy toxicity team at Hopkins, and they have actually developed guidelines about what to do in the setting of patients who are on immunotherapy that come in with sort of a broad differential of pneumonitis and versus COVID-19 infections, and how to approach use of steroids and things like TOSI that we were talking about earlier. There is no hard data right now, and so we're just trying to get a consensus across our home and immunotoxicity team about how to approach these patients.
Thank you, guys.
Okay.
Roy, if I may, just one more thing. We just got another message from one of our fantastic patient advocates who are on the panelists. I think that's an important issue. Patients are obviously concerned. And I think if our colleagues in industry can ensure or communicate with the community if there are going to be any disruptions in the supply chain for some of the medications that our patients are taking, I think that's going to be very important. So if you can, via your websites and other ways, inform us if there are going to be issues, especially related to some of the drugs that our patients are on. I think that would be an important step for both us and for our patients. So I think we're running out of time. So Roy, did you want to go around and ask everybody for final comments?
Yeah, I'll just say, normally I would stop now, but the Yankee game I'm always going to go to has been canceled, sadly. So here's what we'll do. 5 minutes. I think this has been an amazing discussion, and I've learned a lot from everyone's experience. I go to the hospital each day and with my colleagues, and you all do, and we're taking care of patients. We've heard a bit about how we've had to modify some of our research protocols. We're doing the best we can. The good news is we've made some good progress in lung cancer, in radiation, surgery, medical oncology, social work, supportive care, and we can do a lot of it by telehealth, but it's not the same. And we have to make sure during this time that we really focus on our patients, because imagine how scary it must be for them just to have cancer to begin with, and now to have to deal with all this. But as we go around, just to end, and I thank everyone for their time on this Saturday morning, this is a lightning round, just 30-second last thoughts. I know Brandon had his hand up, so I'll start with him. I'll call on you, just a little thought to leave us with, and we're going to do this again. Don't worry. Okay, Brandon.
Yeah, two thoughts, I guess, with the end. Just say compassion for your patients. It's an incredible thing that they're going through right now. And compassion for all the other people working in the hospital. It's a tremendous team effort. I think the one thing, too, just imagine what this is going to do to lung cancer research. It's really going to set it back. It's going to set back young investigators who are slowing down. Funding is going to be diverted. So what else can industry do? They can support the people out there who are really in for lung cancer. And when we get through this, we'll need a lot more research support from them as well.
Beautifully, surgically done. Marty.
I would certainly echo that. I think that at the end of this, and even during it, we can't lose sight of the fact that there is importance to, human-to-human interaction. Yes, I think all of medicine will be changed, with telehealth, but I don't think that it substitutes for doing a proper histories and physicals, and we still are going to need that. Probably the good part that'll come out, as people have mentioned, is that we're going to question many of the quote routine things that we've done, particularly on clinical trials that are so utterly unnecessary. And the best to everybody. It is a very scary time.
Kristen.
Yes, I echo all of these things. I think what has come out of this that's inspiring is we are all a family. So taking care of our patients, our coworkers, our biologic families, and everybody, we're going to keep going forward.
I hope.
Unmute myself. I think it's been really heartening to hear all of this from the lung cancer standpoint coming from the breast cancer world. And I want to thank all the panelists for taking their time on a Saturday to communicate with the community at large, to answer questions, and to so generously donate their time. And for Marina in particular, just to say that, we're all working on this together.
Yeah, I couldn't agree more. And
two things. One is we need more testing. It's becoming crystal clear. We're operating without the right tools, the right assays to figure out what our patients and our healthcare workers have. So we need to do better with that. But I think, as others have said, this is really transformative, not only in telemedicine and reducing scan frequency and thinking about what we do very carefully and more judiciously, but it really is transformative, I think, in how it connects everybody. I don't know about you, but I've been talking more frequently to patients. I've been talking more frequently to staff and all of our, basically on the phone and on Zoom all day. So I think it really does connect us as a community.
Thanks, Kurt.
I think I will echo what everyone has said. This is a challenging time, but there are beautiful things coming out. We're all working together. We are getting the best out of us, and we're generating resources that will linger beyond this time. We're going to learn lessons. We're going to be much better prepared the next time, hopefully, and some good stuff will come out of this and will stay for our patients.
I like that. Tafik.
Yeah, I want to echo everything that's been said. I want to emphasize that this is a real problem. It's not overblown. Having a patient of mine in the ICU on the vent makes it really real, COVID and lung cancer. We also have to remember to take care of ourselves, keep ourselves safe, but that is the only way we can ensure that we're going to be there for our patients long term. Thank you.
Thanks, Corey.
I echo everything everybody else said. I detest the term social distancing. It is physical distancing, but not social distancing. We are now having family meals with my far-flung kids and grandchildren in New York City and Atlanta, FaceTiming a lot more than we've ever done in the past. And I agree with Anne. I think universal testing and rapid testing is key. Marina could comment on this, but I know there's one small town in northern Italy, 3,000 or so, where everyone was tested and they were able to cut down on new cases and mortality. So I think that will help us more rapidly reduce both mortality and ultimately return us to some semblance of our normal lives. This is so emotionally and psychologically disrupting, not just for our patients, but certainly for us.
Jeff?
Yeah, the information will continue to evolve. about 20 radiation oncologists around the world completed yesterday a Delphi consensus statement with 3 or 4 different case scenarios under two situations, an early pandemic or a late pandemic, including our Italian colleagues and some folks from China. So look for more information to come out as to what people would do under certain situations.
Marina, how can we thank you enough for joining us? And a lot of people have learned, and this is going to help save lives in this country based on your experience. We've read some of the things in the cancer letter and other, but talking to you, a lung cancer expert, has been so helpful. Any final thoughts and words of advice for us?
Yeah, so my final thought is that we must think that we are all together, that we can fight the virus and win the battle if we are all together as doctors, but all together also with the citizens, with the politicians. So we must be all together. And the sharing, I think that is key, because if we are in touch all the time with the guidelines, with the ideas, with everything, we can do more.
Okay, I'm going to turn it over to Haas, but I'm going to give you some thoughts, and then I want to thank Axiom for hosting us today, and we're going to hear a few words about how you can see the recorded content. But I'll just say that, I've seen our team come together, and it just didn't happen. We've built teams, all of us, and we've worked as teams, and now people are coming together to care for our patients. I have noticed that people are more available for meetings. It used to be we held a meeting to discuss a grant or a new project, and now everyone's on. And one scientist said, a very wise one at Yale the other day, maybe an hour or 2 in the library can be worth 3 or 4 in the lab, and we can read all of each other's papers and, talk to patients. And let's not forget to talk to our patients and do programs. We're doing some programs for our patients and our advocacy groups, and I think the more of those, and we have many of those people on today, but we'll get through this as a team. And now I'm going to turn it over to Haas. It's been a pleasure working with you and everyone today to close it out and to turn to the Axiom people. Haas.
Thank you so much. I cannot thank all of you for spending your Saturday morning with us. I think this has been a great program. There's not much else I can add. I would continue to ask everyone to collaborate as much as you can. There are databases, just like Marina just mentioned, that I think it's important for us to participate in and contribute so that we can learn from each other's experience. I think that the one thing about the Thoracic group has always been that we've been very international, very inclusive. Everybody works together. You all can see the unselfish way our Italian or Spanish colleagues are participating and doing things. I think if we can all continue to do that, we will find a solution to this problem, just like we have found solutions to many other problems and issues that we have faced. So let's work together. And again, I'd like to thank the Axiom group for putting this together in a very short notice, and they will provide us with some information about how to access the recorded program. Also, stay tuned for another program, hopefully next Saturday, maybe with a little bit of a different cast of characters and different topics, but definitely something that we think we can continue.